So let us continue our discussion for Unit 2, the overview of professional nursing. So for this slide, we will be focused on discussing the communication skills. As I've mentioned earlier, one of the course outcomes is to implement a good communication skills to establish a therapeutic relationship with your patient, with the significant others, and any families of the clients of or your patients. So let's talk about communication. So let's define what is a communication. Communication is a critical skill for nursing. It is the process by which meets their survival needs, build relationships, and experience emotion. In nursing, communication is a dynamic process used to gather assessment data, to teach and persuade, and to express caring and comfort. It is an integral part of the helping relationship. So we all know that the relationship that we have with our patient is what we call the helping relationship. Now, in order to help our patient, we must communicate with them. Why? Because we need to assess, we need to learn their needs. Without communication, we will not be able to understand their needs. Now, we have what we call the communication process. A face-to-face communication involves sender, message, receiver, and a response or feedback. In its simplest form, communication is a two-way process involving the sending and the receiving of a message. Because the intent of communication is to elicit a response, the process is ongoing. The receiver of the message then becomes the sender of a response, and then the original sender then becomes the receiver. So, it will not be called as communication process if there will not be a response. Okay? So, the process is ongoing, and then the cycle will go on. If you will be the sender, then you will become the receiver. The receiver will become then a sender. So, it depends. And it should be, the communication process should end with a feedback. Okay? So, we have here the components of your communication process. First, we have the sender. The sender is a person or group of people who wishes to communicate a message to another person or group. They can be considered the source encoder. This term suggests that the person or group sending the message must have an idea or reason for communicating and must put the idea or feeling into a form that can be transmitted. So, if as for now, I am the sender of this communication process. So I will relate to you the information that you have to learn, the knowledge that you have to learn. Now, the message, the ideas, the discussions that I deliver is what we call the message. The second component of communication process is the message itself. What is actually said or written, the body language that accompanies the words, and how the message is transmitted. The method used to convey the message can target any of the receiver's senses. It can be touch, it can be eyes, it can a sense of sight, it can be the sense of hearing. So either way, we can target different receivers' senses. Another component is the receiver. Now, the receiver is the third component of the communication process. The listener, they are also known to be the listener. The listener who must listen, observe, and attend. This person, if the sender is known to be the encoder, this person is known to be the decoder. Okay? Who must perceive what the sender intended or interpretation. Perception uses all the senses to receive verbal and non-verbal messages. To decode means to relate the message perceived to the receiver's storehouse of knowledge and experience and to sort out the meaning of the message. So as for this moment, or as for this video, I am the sender, and everything that I say is the message, and you will now be the receiver. Now, once you receive my message, when you receive my discussion, you will now give feedbacks, and that feedback is your response. Okay, so that will be your fourth component of your communication process, the response or feedback. The fourth component of the communication process, the response, is the message that the receiver returns to the sender. It is also called as feedback. The feedback can be either verbal, nonverbal, or both. Nonverbal examples are the nod of the head or a yawn. Either way, the feedback allows the sender to correct any or to reword a message. So in the case of Mr. Johnson or any examples, the receiver may appear irritated or say, well, the nurse on the other shift gives me pain medication early if I need it. The sender then knows the message was interpreted accurately. However, now the original sender becomes the receiver, who is required to decode and respond. Okay? So that is the components of your communication process. Again, we have the sender, we have the message, we have the receiver, and we have the response or your feedback. Now let's talk about the different modes of communication. So we have here the verbal and electronic and non-verbal communication. Now let's talk about first the verbal communication. This uses the spoken or written language or written word. Non-verbal communication use other forms such as gesture or facial expression and touch. So this one dito po sa here in verbal communication, we use our ability to write and our ability to understand speech. Another, we have electronic communication. A common form of electronic communication is email, in which an individual can send a message by computer or to another person or group of people. Nurses need to know when it is and when it is not appropriate to use email for communicating with clients. So actually, and nowadays, telehealth or telemedicine is implemented. Now, with the use of telehealth and telemedicine, we use emails to communicate with our clients. Now, that is what we call electronic communication. However, the problem with electronic communication is the data privacy, confidentiality. Why? Because we all know that in internet, there are big, memory storages that could back up your messages, and that can be stayed for and how many years, and then can be read by different people if you don't have a good data privacy and applications installed in your cell phones or hospitals itself. So another mode of communication is your non-verbal communication. Now, the non-verbal communication has different components. First, your personal appearance. This may include clothing and adornments. That can be sources of information about a person. Although choice of apparel is highly personal, it may convey a social or financial status, culture, religion, group association, and self-concept. So it basically depends on how a person sees you. Your physical appearance. If you have, usually we use physical appearance as if we have good demeanor, okay. If we have pleasing personality, it may also include your physical appearance. Another nonverbal communication is your posture and gait. The way people talk, walk, and carry themselves are often reliable indicators of self-concept, current mood, and health. So we can really differentiate those introvert and extrovert people, those who have confidence and those who doesn't, or those who don't. Okay? So another is facial expression. No part of the body is as expressive as the face. Feelings of surprise, fear, anger, disgust, happiness, and sadness can be conveyed by facial expression. Another is your gestures. Hand and body gestures may emphasize and clarify the spoken word, or they may occur without words to indicate a particular feeling or to give a sign. Okay? So again, electronic communication, computers are playing an increasing role in the nursing, practice. Many healthcare agencies are moving toward electronic medical records where nurses document their assessment and nursing care. So we have actually electronic health record that are some of the hospitals right now, even in the Philippines, uses this kind of record. So with this record, we're capable to check information online and offline. So email can be used in healthcare facilities for many purposes, such as to schedule and confirm appointments, report normal lab results, conduct client education, and for follow-up discharged clients. So email is the most common form of electronic communication, and it is very important for the nurse to know the advantages and disadvantages of electronic or email. Also, other guidelines to ensure client confidentiality. Now, we will understand or discuss the advantages and disadvantages of your electronic communication. First, so we have here the different advantages and disadvantages. Advantages may include fast, efficient way to communicate, and it is legible because it is not based on handwriting, because it is based on what we type, and we can type efficiently and legibly because the Word or the Microsoft is capable of correcting your grammar, correcting your spelling. So it provides a record of the time and date of the message that was sent or received. Some health facilities provide information to their clients on how they can reach via email specified staffs. This improves communication and continuity of client care. Email promises better access, and evidence has shown that clients and healthcare providers are willing to use internet. Next, the disadvantages. One disadvantage or negative aspect of email is concerned by both clients and primary care providers regarding privacy, confidentiality, and potential misuse of information. Because, again, as mentioned earlier, your emails can be accessed for how many years, especially if it's in the internet. So protection of client privacy remains an issue when transferring information electronically. The healthcare agency needs to have an email encryption system to ensure security. An agency may have its own system to outsource it to an encryption service. Okay? So now let's talk about the different factors that could influence communication process. So we have here development, gender, values and perceptions, personal space, territoriality, roles and relationship, environment, congruence, interpersonal, attitudes, and boundaries. So let's define it one by one or understand it one by one. First, we have here development. This includes language, psychosocial, and intellectual development through stages across the lifespan. Knowledge of a client's in developmental stage will allow the nurse to modify the message accordingly. So if we know who we talk with, who do we talk with, or who do we talk to, we are capable of changing our language, our use of language, depending on the capacity of that individual to understand it. So we change our use of words when we talk with patients, elder patients. We change our language when we talk with clients who are children. We use more simpler words compared to what we use to other older adults. So another factors is gender. From an early age, females and males communicate differently. From the time we were born, we have innate characteristics. That's why we differ from males. Now, girls tend to use language to seek confirmation and establish intimacy, while boys use language to establish independence and negotiate status within a group. So, that's why we have what we call nowadays love language. Women needs words of affirmation, while men don't. Because we women Okay, we females believe that communication is the key for a long-term or a good relationship. Okay? Another is values and perceptions. Values are the standards that influence behavior, and perceptions are the personal view of an event. Because each person has unique personality traits, values, and life experiences, each will perceive and interpret messages and experiences differently. It is important for the nurse to be aware of a client's values and to validate or correct perceptions to avoid creating barriers in the nurse-client relationship. The very first thing that we need to apply and to learn is self-awareness. You need to be aware of your own principles, of your own beliefs, and your own principles. Because when we talk with our patient, when we assess them, we do not coerce what we believe to be right and to be wrong. We have to respect their own opinions, their own perceptions, their own knowledge. Okay? However, if there are misconceptions regarding health, then we can correct them. But we never coerce them with what we think is right. Okay? So it is important for the nurse to be aware of the client's values and to validate them. Next, we have here personal space. Personal space is the distance people prefer in interaction with others. Proxemics is the study of distance between people and their interaction. Middle class North Americans use definite distances in various interpersonal relationship along with specific tones and body language. The more that we are closer to people, the more intimate the relationship. That's what we believe. That's why we have to respect personal boundaries, personal space. Now we have intimate about 0 to 1.5 feet. That's intimate. Now, we use intimate spaces if the patient needs comfort, if the patient needs safety, especially if they came from a abusive relationship and they need affirmation or touch. So we can use intimate personal space. However, it is not usually or always used. Another, we have personal space, about 1.5 or 2 or 4 feet. We have social, 4 to 12 feet, and public, 12 feet and beyond. So all of these spaces is or must be respected. Okay? When we talk to our patient, we can either use personal space, intimate space, social, or public space, depending on the client we serve. Another factors that influence our communication process is territoriality. It is a concept of the space and things that an individual considers as belonging to the self. The territories marked off by people may be visible to others. For example, clients in a hospital often consider their territory as bounded by the curtains around the bed unit or by the walls of a private room. Health workers must recognize this human tendency to claim territory. Clients often feel the need to defend their territory when it is invaded by others. For example, when a visitor or nurse removes chair to use to another bed, or you will open the curtain. So definitely you are now invading their privacy. Huh? The visitor has invaded territory, violated the territoriality of a client whose chair was removed. Nurses need to obtain permission from clients to remove, rearrange, or borrow objects in their hospital area. So another factor is your roles and relationship. The roles and relationship between sender and receiver affect the communication process. Roles such as nursing and instructor, a client and a primary care provider, or a patient or a parent or child affect the content of responses in the communication process. The, that's very true. No? When you talk with your CI with utmost respect, when you talk with your client, there's the respect, but somehow you use simpler terms for them to understand you. Now, when you talk with your colleagues, it's also different because you have certain the same knowledge of a certain language, so you are capable of using the same language. Okay, so the tone, the choice of words, the sentence structure, and the tone of voice vary considerably from role to role. So if your role is caring, so you cannot command, you cannot ano to, because make instruction to your patient in a commanding voice. It should be in a warm voice. So in addition, specific relationship between communicators is significant. The nurse who meets with a client for the first time communicates differently from the nurse who has previously developed a relationship with that client. Not because, yes, they are all clients, we're all the same nurses, but because you have met for the first time the patient, you have to respect their boundaries first. So, you have to be careful of the things that you mention, the things that you do as part of your nonverbal communication. So, another factor is your environment. People usually communicate most effectively in a comfortable environment. Your temperature, the temperature extremes, excessive noise, and a poorly ventilated environment can all interfere with communication. Also, lack of privacy may interfere with the client's communication about matters the client considers private. For example, a client who is worried about the ability of his wife to care for him after discharge from the hospital may not wish to discuss this concern with a nurse within hearing of other clients in the room. Environmental distraction can impair or distort communication. That is why, in order to provide privacy, if you are assigned or the patient is in ward, drawing the curtains, because respecting the personal spaces and boundaries will help you get the trust of your patient and ensure the patient's confidentiality. So what was discussed in the bed or in the four walls of that room should stay there. What is not, it should not be raised in a station or raised in the hallway of hospital wings. Another factor is your congruence. In congruent communication, the verbal and non-verbal aspects of the message match. So in congruency, when we talk about congruency, it's the matching or connection of the things that we do as a part of your non-verbal communication and the things that we say as part of your verbal communication. Clients more readily trust the nurse when they perceive the nurse's communication as congruent. This will also help to prevent miscommunication. Both nurses and client can easily determine if there is congruence between verbal expression and non-verbal expression. Nurses are taught to assess clients, but clients are often just as adept at reading nurses' expression or body language. If there is an incongruence between verbal and non-verbal expression, the body language or non-verbal communication is usually the one with true meaning. So the example, you talk with your patient. Now, in a good tone, however, the looks of your eyes is in a judgmental way of looking. So definitely the patient will feel uncomfortable and he or she will feel judged by you. So we have to control our facial expressions, our nonverbal communications. So another factors may include interpersonal attitudes. Attitudes convey beliefs, thoughts, and feelings that about people and events. Attitudes are communicated convincingly and rapidly to others. So this may include a caring and warmth attitude, which can convey a feeling of emotional closeness in contrast to an impersonal approach. Another, respect. It is an attitude that emphasizes the other person's or worth and individuality. Another is acceptance, emphasizes neither approval nor disapproval. So when we talk with our patient, there's no correct, there's no wrong. Okay? Everything that they verbalize, we have to respect that. Otherwise, if it's a misconception, again, if it's a misconception about health, then you can correct them. But if not, if it's about their personal views, their personal attributes, then we cannot correct them. Now, another factor is your boundaries. These are defined by Boyd as limits of individuals, objects, or relationships. For nurses, professional boundaries are crucial in the context of nurse-client relationship. To keep their boundaries, the nurse keeps off the focus of to keep clear boundaries, the nurse keeps the focus on the client and avoids sharing personal information. Because the moment we share personal information, we will now letting the patient felt distant of you. Even though you have the same experience, try to avoid as much as possible personal information about you. If the client seeks friendship with the nurse or a relationship with outside of the work, the nurse affirms his or her professional role and declines the invitation. So now let's talk about the characteristics of a good communication. How can we identify if the process that we use as a communication with our clients is a simple communication? First, simplicity. It indicates the uses of commonly understood brevity and completeness. Another is clarity. It involves saying what is meant. The nurse should also need to speak slowly. Next, timing and relevance. This requires a choice of appropriate time and consideration of the client's health or interest and concerns. Ask one question at a time and wait for an answer before making one another. Next, adaptability. Involves adjustments on what the nurse says or how it is said depending on the moods and behavior of the family. Next, we have credibility. Means worthiness of belief. To become credible, the nurse requires adequate knowledge about the topic being discussed. It should provide accurate information to convey nursing confidence in certainty. Okay? Next. Okay, so that is for your characteristics of good communication. Again, we have clarity, simplicity, timely and relevance, adaptability, and credibility. So now let's talk about the 4 shapes that other people these are the characteristics of a good communication. So again, simplicity, clarity, timing, relevance, adaptability, and credibility. Now let's talk about how do we communicate with clients who have special needs. So when we say about special needs, this may include clients who cannot speak clearly, which they have aphasia, dysarthria, or muteness, clients who are cognitively impaired, clients who are unresponsive, and communicating with hearing impaired clients. So another din is we have a client who do not speak English. So isa-isa, let's identify this one by one. So first, a client who cannot speak clearly, either she or he has aphasia or a difficulty of speaking, dysarthria, difficulty of articulating words, and muteness. Literally, they cannot speak any words. So you have to listen attentively, be patient, and do not interrupt them. Ask simple questions that require yes or no questions. So as much as possible, avoid using open-ended questions here. Allow time for understanding and response. Use visual cues such as words, pictures, or objects. Allow only one person to speak at a time. Do not shout or speak too loudly. And use communication aids such as pad and felt tip pen, magic slate. Next, clients who are cognitively impaired. First, reduce environmental distraction while conversing. Get clients' attention prior to speaking. Use special sentences and avoid long explanation. Ask one question at a time. Allow time for client to respond. Be an attentive listener. Include family and friends in conversation, especially in subjects known to client. So another, for client who are unresponsive, so meaning ito yung mga patient, these are the patients who are unconscious, okay, or unable to speak due to trauma or anything that happened to them. Call the client by name during interactions. Communicate both verbally and by touch. Speak to client as though he or she could hear. Explain all the procedures and sensations. Provide orientation to place, person, and time. Avoid talking about client to others in his or her presence, and avoid saying things and client should not hear, because it's okay, the patient is unresponsive, he or she is unconscious, it's okay to talk about like this kind of. No, we should avoid that one, because we never know when the patient can be responsive and can be conscious. Next, communicating with hearing impaired clients. So first, you need to establish a method of communication, either a pen, a pencil, or paper, or sign language. Pay attention to clients' nonverbal cues. Decrease background noise such as television. Always face the client when speaking. And it is also important to check the family as to how they communicate with the patient. Another, client who do not speak English. This is very common to different or some of the Asian countries, because not all Asians are capable of speaking English. And even in Middle East, Arabs cannot speak in straight English. They use a broken English to speak with their nurses. So, speak to client in normal tone of voice. Shouting may be interpreted as anger. So do not be frustrated with talking to them. You use other means of communication. You can ask interpreter if there is an available interpreter in the hospital. Establish method for client or signal desire to communicate. Or you can provide an interpreter as needed. Avoid using family members, especially children, as interpreters, because they have different knowledge and understanding. Develop communication board, pictures, or cards. Have a dictionary, either English or Spanish, available if the client can read. However, if the patient cannot read, then there's nothing we can do by using the dictionary, because the patient cannot read. So now let's talk about the therapeutic communication in nursing. So as mentioned in the course outcome of this subject, after learning the course subject, you will now capable of implementing therapeutic communication in nursing. Now, what is therapeutic communication? So, from the word therapeutic plus communication. So, when we talk about therapy, it is an intervention that would improve the well-being of a person. Now, therapeutic communication promotes understanding and can help establish a constructive relationship between the nurse and the client. Unlike a social relationship where there may be or may not be a specific purpose or direction, the therapeutic helping relationship is client and goal directed. Nurses need to respond not only to the content of a client's verbal message, but also to the feelings expressed. It is important to understand how the client views the situation and feels about it before responding. The content of the client's communication is the words or thoughts. As distinct from the feelings, sometimes people can convey a thought in words while their emotions contradict the words. That is, words and feelings are incongruent. For example, a client says, I am glad that I am glad he has left me. He was very cruel. However, the nurse observed that the client has tears in her eyes as she says this. To respond to the client's words, the nurse might simply rephrase saying, you are pleased that he has left you. To respond to the client's feelings, the nurse would need to acknowledge the tears in the eyes. So for example, saying, you seem saddened by all of this. Yes, you were you are pleased that he has left you. However, you seem saddened by all of this. Such a response helps the client to focus on her feelings. In some instances, the nurse may need to know more about the client and her resources for coping with these feelings. So here are different therapeutic communication skills that we can use when we talk with our patient. First, attentive listening. It is type of a listening that that involves actively listening with mindfulness, using all the senses and paying attention to what the client says, does, and feels, as opposed to listening passively with just hear. Because when we listen passively, the tendency is after we listen to the words, it will be not placed in our minds. It is not truly understood by the receiver. Now, if we do active listening, the words can be interpreted in our minds and be understandable but in easier way. Most important technique in nursing, it is basic to all techniques. Attentive listening. Next, visibly tuning in. At times, your nonverbal behavior may be as important or more important than your words. Egan describes key nonverbal skills that can be used to visibly tune in to clients, which is an expression of empathy that tells clients that you are with them, and it puts you in a position to listen carefully to their concern. So, by simply nodding your head, by simply providing some nonverbal gestures, this can tell that the patient, or you as the nurse, this can tell the patient that, okay, the nurse is really listening to my complaints, to my experiences. So, next, we have here using silence. Okay. This accepting pauses or silences that may extend for several seconds or minutes without interjecting any verbals. So sitting quietly and waiting attentively until the client is able to put thoughts and feelings into words. So if you give time to your patient to collect their ideas, to collect their emotions, to collect their feelings, then probably they can give a good response to certain questions. Next, providing general leads. Saying statements or questions that encourages client to verbalize, choose a topic of conversation, and facilitate continued verbalization, such as can you tell me how is it for you? Perhaps you would like to ask about like this. Would it help to discuss your feelings? Where would you like to begin, and then what? So this type of statement can increase the verbalization of feelings of clients. Next, being specific and tentative. Making statements that are specific rather than general, and tentative rather than absolute. Sample, rate your pain on a scale of 0 to 10, which is 0 is no pain and 10 is the very painful. Or are you in pain? It's a general statement. So it answers yes or no questions. You seem to be unconcerned about your diabetes. That is tentative, because the word of seem. So you give out some of your own assumptions. Okay. Next, using open-ended questions, asking broad questions that lead or invite client to explore, elaborate, clarify, describe, compare, and illustrate thoughts or feelings. Open-ended questions specify only the topic to be discussed and invite answers that are longer than one or two words. So example, I'd like to hear more about that. Tell me more. How have you been feeling lately? What brought you here to the hospital? What is your opinion? You say you were frightened yesterday. How do you feel now? These are just example of using open-ended questions. Next, using touch. Providing appropriate forms of touch, reinforcing caring feelings, because tactile contacts vary considerably among individuals, families, and cultures. The nurse must be sensitive to differences in attitudes and practices of clients and self. So here, as a practicing Muslim, it is not really accepted to touch another or opposite sex. However, in the profession, in the line of our duties, in the line of our profession, so it is accepted, but in a professional way, not in personal way. Next, restating or paraphrasing. Actively listening for the client's basic message and then repeating those thoughts and or feelings in similar words. It conveys that the nurse has listened and understood the client's basic message, and also offers clients a clear idea of what they have said, because sometimes clients may experience confusion. Now, when you restate their words, when you rephrase their words, they can understand, they can correct or verify the things that they have said if it's not correct, no? So clients, example, client, I couldn't manage to eat any dinner last night, not even dessert. Now, the nurse, you had difficulty eating yesterday. Now, the client would answer, yes, I was very upset after my family left. So another technique or another therapeutic technique is your therapeutic communication technique is your seeking clarification, a method of making the client's broad overall meaning of the message more understandable. It is used when paraphrasing is difficult or when the communication is rambling or garbled. To clarify the message, the nurse can restate the basic message or confess confusion and ask the client directly. No, you can ask the nurse can also clarify their own message with statements. So, such as, I'm puzzled. I'm not sure I understand that. Would you please say it again? So, pardon. Can you please repeat everything that you say? So you can do that, no? To respect or to seek clarification from what the patient have stated. Another technique, therapeutic communication technique, is perception checking or seeking consensual validation. A method similar to clarifying that verifies meaning of the specific words rather than the overall meaning of a message. So example, client, my husband never gives me presents. Nurse, you mean he has never given you a present for your birthday or Christmas? Client, well, not never. he does get me something for my birthday and Christmas, but he never thinks of me giving anything at any other time. So you will now conclude that the patient's husband gives gifts, however, not often as she expects to. Next is offering self, suggesting one's presence, interest, or wish to understand the client without making any demands or attaching conditions that the client must comply with to receive the nurse's attention. So example, we have, I'll stay with you until your daughters arrive. We can sit here quietly for a while. We don't need to talk unless you would like to. I'll help you to the dress to go home if you like. So another is giving information, providing in a simple, direct manner specific factual information the client may or may not request. So when information is not known, the nurse states this and indicates who has it and when the nurse will obtain it. So giving information in a simpler and a direct manner, it will help the patient understand their health status. So example, your surgery is scheduled for 11 a.m. tomorrow. You will feel a pulling sensation when the tube is removed. So in this way, you can alert the patient of what to expect in your relationship. Another is acknowledging, giving recognition in a non-judgmental way of a change in behavior, an effort the client has made, or a contribution to a communication. Acknowledgement may be with or without understanding, non-verbal or verbal. Example, you trimmed your beard and mustache and washed your hair. I notice you keep squinting your eyes. Are you having difficulty seeing? You walked twice as far today with your walker. So acknowledging and recognizing the efforts made by the clients would improve their well-being. Another is clarifying time or sequence, helping the client identify or clarify an event, situation, or happening in relation to time. So, such as, I vomited this morning. So, was that after breakfast? I feel that I have been asleep for weeks. You had your operation Monday and today is Tuesday. So, at some point, this is just like orientation. Orientating the patient to time, place, and person. Next, presenting reality, helping the client to differentiate the real from the unreal. So usually we use this type of therapeutic communication skill if the patient has episodes of unrealistic beliefs, such as delusions. No? So we can use this one. So that telephone ring came from the program on television. Your magazine is here in the drawer. It has not been stolen. So next, we have focusing, helping the client to expand on and develop a topic on importance. It is important for the nurse to wait until the client finishes stating the main concerns before attempting to focus. So in Tagalog pa yan, sapaw. Do not make sapaw. Huwag mong sasapawan, or do not make comments on top of what the client says, and then or while the patient is talking. So next, we have reflecting, directing ideas, feelings, questions, or content back to the clients to enable them explore their own ideas and feelings about the situation. So example, what can I do, nurse? What do you think would be helpful? So you redirect the question. So what can I do? So you cannot give suggestions. We must avoid giving suggestive acts. So we ask them, what do you think is more helpful than you? More helpful? Is it like this or like that? What is more advantage or more good? Okay. So next, summarizing and planning. So stating the main points of a discussion to clarify the relevant points discussed. So this technique is usually done when the relationship of the nurse and patient is closing, or on the terminal phase, when the patient is ready to be independent. Okay? So now let's talk about the different barriers to communication. So again, I hope you have learned about the different communication, therapeutic communication technique. Now let's learn what are the barriers to communication. So barriers to communication, nurses need to recognize barriers or non-therapeutic responses to effective communication, such as failing to listen, improperly decoding the client's intended message, and placing the nurse's needs above the client's needs are major barriers to communication. So, as mentioned earlier, nursing is holistic, nursing is client-centered. Everything that the client needs must be given. Okay? If you can do so. No? So, failing to listen, improperly decoding the client's intended message, and placing the nurse's needs above the client's needs are major barriers to communication. So, techniques that could lead to barriers in communication, such as stereotyping, often offering the generalization and biased, oversimplified beliefs about groups of people that are based on experience, too limited to be valid. Another is agreeing and disagreeing. Yung after you talk with your patient, you agree, and then afterwards, I know that's not what I said. I disagree with. So that's really bad. Similar to judgmental responses, agreeing and disagreeing imply that the client is either right or wrong. Remember, all of the feelings, emotions, anything that is the concern of the client, other than the health information, they cannot be right or they cannot be wrong because it is a subjective data. It is only coming from your patient. Another being defensive, attempting to protect a person or health care services from negative comments. Another, challenging, giving a response that make clients prove their statement. Oh, when you ask a patient, oh, is that true? Really? Do you think? Yeah. So you question now the credibility of the information that came from the patient. So another is probing, asking for information chiefly out of curiosity rather than with the intent to assist the client. Example, the husband and wife fought during your assessment, and then you ask the patient, you probe them, why did you fought? Any problems? Like that, so and so. Oh, I have also my problems too, like that. So that's probing. That's not good because there will come a time that the patient will tell you, you're so very nosy, right? So next is testing, asking questions that make the client admit to something. These responses permit the client only to limited answers and often meet the nurse's need rather than the client's. So who do you think you are? Do you think I am not busy? So just like that. So you give assumptions. Another, rejecting, refusing to discuss certain topic or topics with the client. Another, changing topics and subjects, directing communication into the areas of self-interest rather than considering concerns. Considering the client's concern is often self-protective response to a topic that causes anxiety. Next, we have unwanted reassurance. When you say that everything's gonna be okay, but it's not. So that is unwanted reassurance. Using cliches and comforting statements of advice as means to reassure the client, these responses block the fears, feelings, and other thoughts of the client. Next, giving opinions and approving or disapproving responses, moralizing, implying the client must must think as the nurse thinks, fostering client dependence. Next, we have given common advice, telling the client what to do. These responses may deny clients' right to be an equal partner. Note that giving expert rather than common advice is therapeutic. Okay, so that's all for your barriers to relationship. Now, let's talk about the nurse-patient relationship, or what we call the helping relationship. Nurse-client relationships are referred to by some as interpersonal relationships, such as by others therapeutic relationships, and by still others as helping relationships. Helping is a growth facilitating process that strives to achieve three basic goals. Now, help clients manage their problems in living more effectively and develop unused opportunities more fully. Help clients become better and helping themselves in their eyes every day of their lives to develop an action-oriented prevention mentality. A helping relationship may develop over weeks of working with a client within clients. So, the key to helping relationship are development of trust and acceptance between the nurse and the client, and the underlying belief that the nurse clients attends and wants to help the client. Now, let's talk about the different phases of this nurse-patient relationship or helping relationship. First, helping relationship process can be described in terms of 4 sequential phases, each characterized by identifiable tasks or skills, and relationship must progress through these stages and in succession because each builds on the one before. Nurses can identify the progress of a relationship by understanding these phases, namely pre-interaction, introductory or interaction phase, working phase, and terminal phase. So first, we have pre-interaction. The nurse reviews pertinent assessment data and knowledge, considers potential areas of concern. So here, we study the charts of the patient. We study the details, we study the assessment of doctors and diagnosis of the doctors. Next, in introductory phase, we will open the relationship. Both client and nurse identify each other by name. When the nurse initiates the relationship, it is important to explain the nurse's role to give the client of the direct of what to expect when the client initiates the relationship. Next, we have clients. We have clarifying the problem. Because the client initially may not see the problem clearly, the nurse's major task is to help clarify the client. Next, structuring and reformulating a contact. All obligations to be met by both and the nurse. So, nurse and client develop a degree of trust and verbally agree about location. So, another is the nurse may develop a degree of trust or verbally accurate about location, frequency, length. So next is overall purpose of the relationship. How confidential matter will be handled and tasks to be accomplished, and duration of indication or termination of the relationship. Another is your termination phase. Nurse and client accept feelings of loss. The client accept the end of the relationship without feelings of anxiety and dependence. For skills, the nurse summarizing. For the nurse, the summarizing skills for the client, for the nurse, summarizing skills for the client, ability to handle problems independently. Okay, so in conclusion, communication skills is a great and a foundation of good therapeutic relationship. Once you build a good communication with your patient, then the relationship will be therapeutic as possible. So again, when we mention therapeutic, meaning you are improving the well-being of the patient. You are providing the needs of the patient. So thank you for watching this video. I hope you have learned a lot in this video. So if any questions, clarification, you can ask me, okay, directly sa ating messenger if ever malinis na. Or if there's problem with the resources, then you can always chat or message me in this platform. So thank you for your time. I hope you understand everything I discuss in the class. So thank you once again and good day.